Hello everyone, thank you so much for tuning in. This is Dr. Sam Omar, and today's lecture is going to be about dental implants. It's called the 5 dimensions of successful treatment planning. This is a very important topic, and I really wanted to speak about that topic for quite a long time, and today is the day I chose to speak about this topic. So again, the 5 dimensions of treatment planning. My name is Dr. Sam Omar. This is my email, dr.samomar@gmail.com. A little bit of information about myself. I'm a general dentist with a private practice in Cairo, Egypt, exclusive to implantology and restorative dentistry. I'm a resident at the prosthetics department at Cairo University, also a member of the R2 Digital Center's development and education team, an R2 Gate and R2 Digital Oral Design trainer, international lecturer and speaker on digital implantology, guided surgery, and one-day implants protocol, and an active member of the Digital Dentistry Society DDS. Without further ado, let's start to speak about our topic today, the 5 dimensions of successful treatment planning. I have been lecturing about the 5 dimensions of treatment planning since 2017, and that's why I'm really happy that I'm going to be sharing this concept with you today. So let me show you the content of today's presentation. So we'll start with why the 5 dimensions of treatment planning, why was it developed, and what is the theory and the rationale behind the 5 dimensions. The 5 dimensions of treatment planning will help you position your implant in an ideal position according to each case or site. And how could you increase your success rate and improve long-term results of the implants you placed? What are the considerations that you have to keep in mind when you're planning an immediate implant placement? AP spread, premolar versus molar occlusion, when and why? What is the difference between custom and stuck abutments and when to use each of those? How do we assess bone stability in future implant sites, and how do we customize drilling protocols? What are the objective methods to measure implant stability and making the right decisions about immediate loading or delayed loading? And in cases of delayed loading, how long should we wait, and how do we avoid the unnecessarily long integration periods? For you to treatment plan a case successfully, you don't only need to treatment plan using a software, you also need to know what would be the ideal implant position and why are you placing the implant in this particular position. Implant planning will be done with a great deal of accuracy. And for that reason, we came up with the 5 dimensions of treatment planning. Those 5 dimensions will be the blueprint that you, whether a clinician or a technician, will use them as a blueprint for you to follow during treatment planning an implant case. The 5 dimensions will allow us to plan in consideration to restorative position, availability of bone and soft tissue, and today, throughout the session, I'll make sure that we cover all the 5 dimensions of treatment planning in great detail. So what is treatment planning for implants? The process of positioning an implant in an ideal position based on the current circumstances, whether restorative position and availability of bone and soft tissue. This is what treatment planning means. Now, planning is based on 2 main things. Number 1 will be the restorative position, because patients want teeth and not implants. And number 2 will be the availability of bone and soft tissue. Those are the 2 main factors that affect our treatment planning process. Now, with most of the treatment planning softwares out there, the workflow goes as follows. Before you treatment plan an implant case, you get a CBCT scan, you get a model scan, and you merge both of these data together using your treatment planning software. After that, waxup is designed, and then after designing the waxup, the implant will be planned based on the position of the waxup. Now let's go back to the main point. Planning is based on 2 main things: restorative position and then availability of bone and soft tissues. We could always plan the implants to be in the ideal position prosthetically, but does that mean that we'll place the implant in the ideal position in bone and soft tissues? And that's what we'll talk about today. So what are the 5 dimensions of treatment planning? The 5 dimensions of treatment planning are dimension number 1, Bucco-Lingual, dimension 2, Mesio-distal, dimension 3, Apico-occlusal, that includes the relationship to important anatomical structures, bone level, running groom, and native bone engagement. Dimension 4 is relationship to adjacent teeth, implants, waxup, and AP spread. Dimension number 5 is bone density and loading. Dimension number 1, Bucco-Lingual. When we're planning the implant in the treatment planning software, what would be the best position of the implant in a Bucco-Lingual perspective? And how much bone do I really need to have on the buccal and on the palatal of the implants? So a minimum of 1.5 to 2 millimeters of bone on the buccal of the implants is necessary to keep a long-term result for the implant. About 1.8 millimeters according to Spray. The reason being is that this type of bone is usually cortical bone, and cortical bone has what we call low metabolic turnover rate, which means that the capacity of this bone to repair itself is quite diminished. So we need to always keep this bone in a certain thickness, and there's a critical thinness. If we go beyond that thinness, that bone will no longer be viable because the amount of blood supply that goes to this type of bone will be diminished, and then that type of bone is going to start to resort. So we keep that 1.5 or 2 millimeters on the buccal side just to prevent the long-term dehiscence of the labial plate and the subsequent show-through of the implant. The second dimension of treatment planning is the mesio-distal dimension. How much is the distance that we keep between an implant and a tooth? Well, ideally we should keep 1.5 millimeters from the lamina dura of the adjacent teeth to the implants for tissue stability and not to compromise the vitality of these teeth. So the lamina dura is this part right here, this cortical bone, and ideally we should keep about 1.5 millimeters from the lamina dura of the adjacent teeth when we're planning our implant. Now, what about the distance that we keep between two implants? So ideally we should keep about 3 millimeters of bone between two implants when we're planning our implant. The reason why is we would like to avoid the loss of interproximal bone and the subsequent loss of the papilla that would fill in the distance between the teeth, and eventually we'll get what we call the black triangles. Dimension number 3 will be apico-occlusal. In the apico-occlusal dimension, we have to consider number 1, the relationship to important anatomical structures, bone level, running room, and native bone engagement. We'll start with the relationship to important anatomical structures. Well, usually in the maxilla we have 3 structures that we have to be aware of, and in the mandible we also have 3 structures that we need to be aware of. In the mandible, it goes at the back, so we start at the back with the inferior alveolar nerve, and we usually recommend that we keep 2 millimeters away from the inferior alveolar nerve. The reason being, number 1, the minor deviation that might happen during guided surgery, and number 2, the edema that happens due to the drilling might cause some temporary paresthesia, and we would like to go ahead and avoid that. In the middle of the mandible, we have the mental foramen, where is the exit of the inferior alveolar nerve, and we usually try to avoid going into the mental foramen, and we try to stay about 2 millimeters away from the mental foramen. In the midline, we have what we call the lingual foramen, and right now we'll talk about the lingual foramen in detail. In the maxilla, we also have 3 structures that we need to be aware of. In the back, we have the maxillary sinus. So most of the time, we try to avoid going into the maxillary sinus and perforating the Schneiderian membrane, and we can accomplish this with doing an internal sinus. We also try to avoid going into the nasal floor. And lastly is the nasopalatine canal, which is a canal found in the maxillary midline, and we'll talk about this also in more detail right now. So the lingual foramen is a small opening situated on the lingual or the tongue side, which is right here. And this lingual foramen usually contains small blood vessels. Well, what we try to do is we try to avoid injuries to the lingual foramen to avoid sublingual bleeding in this sublingual space. The nasopalatine canal is a canal that is found in the midline of the maxilla, and it's a heart-shaped canal, as we can see here. And ideally, we try to avoid going into the nasopalatine canal to avoid post-op numbness and prosthetic complications in partially edentulous cases. Nevertheless, this is a very interesting study that we found. This is a study that was done in Spain, published in the Journal of Oral Implantology, where implants were placed in the nasopalatine canal after removing the contents of the canal and grafting it. It shows about 84.6% success rate after a mean follow-up of 17 months. So what we could do right now is remove the contents of the nasopalatal canal, graft it, and place implants into it if we have to. Under dimension number 3, apico-occlusal, is bone level. And by bone level, we mean where do we place the implants in regards to the crest of the bone. So we have 3 different types of implants, and what we need to do is we need to follow the manufacturer's instructions on whether to place the implants at the bone level, or subcrestal, that would be under the bone level by about 0.5 millimeter to 1 or 2 millimeters. Soft tissue level implants, and that means that the platform of the implant will be at the level of the soft tissue. Also running room, and running room refers to the apical-coronal distance between the implant platform and the zenith or the highest point of the gingival margin. This distance right here is what we call the running room. And ideally we should keep about 3 to 4 millimeters from the zenith of the soft tissue to make sure that we create a proper emergence profile, just like what we have in the picture in the middle on the right side right here. This is an image where we did respect the running room distance, and that's why we have a good emergence profile. On the other hand, the picture on the bottom, you see that this is where the implant platform level is, and that's what caused a significant amount of bone loss around the collar of the implant. So inadequate running room due to the lack of soft tissue will result in bone loss as a natural reaction to the implant to recreate biological width. Number 4 would be native bone engagement. We'll need about 4 millimeters of native bone engagement just to make sure that we have adequate primary stability. So when you're planning an immediate implant placement where you'll do the extraction and then you'll place the implant, make sure that your implant or your future implant that you'll place engages at least 4 millimeters to make sure that you'll have good primary stability. So in case number 1, this implant is a 13 millimeter implant, and obviously more than 50% of the implant is engaging bone. That's more than 7 millimeters, so that will be adequate and that will give us good primary stability. On the other hand, in cases like this is where the implant is placed in the sinus, as you can see here. This is a 7 millimeter implant and more than half the implant is actually in the sinus. In these cases, it is actually recommended to delay the implant placement, maybe do a sinus lift, and then later on stage the implant placement. So this is what we call questionable primary stability. At least make sure that you engage 4 millimeters just to make sure that you'll have good primary stability for your immediate implants. Dimension number 4 will be relationship to adjacent teeth, implants, wax-up, and AP spread. So what does that mean? Well, this is a case where we have placed the implant with respect to all the biological considerations. So in this case, we have about 2.2 millimeters on the buccal side, so that's more than 1.8 millimeters, which is the recommended distance. We have 1.5 millimeters from the implant to the adjacent tooth. We have 3 millimeters between the platforms of the 2 implants. But if you see how the implants are emerging in relationship to the teeth or the future wax-up, you'll find that the implant on the right side is actually emerging way too buccal, which means that whenever we're planning an implant, we don't only look at the implant from a biological perspective, but we also have to look at the implant from a restorative point of view, and we need to make sure that this implant could be restored. So when we're planning the implants, we have to be aware of the relationship to the adjacent teeth, the relationship to the implants, wax-up, and AP spread. Let's talk about the relationship to the adjacent implants. So we have to be aware of what is the angle difference between the implants that we're placing. Are the implants parallel or not? The angle between the implants determine the type of abutments that are going to be used to restore the case. Minimal angle difference, like what we have on the right side, is easier to restore. We could use straight stuck abutments. We could use custom abutments if we want. And we could use tie bases for screw-retained restoration. On the other hand, large angle differences between the implants are more challenging to restore, and they require the use of custom abutments in case we're doing cement-retained restorations with big angle differences, or using multi-unit abutments to do a screw-retained restoration if we have a big angle difference. So in a nutshell, make sure that when you're placing your implants, ideally place your implant straight. Number 1, that'll make the prosthetic procedure a lot easier. and will also reduce the overall cost of restoring the implant. So let's talk about the difference between different types of abutments. Let's talk about the difference between stuck abutments and custom abutments. So stuck abutments are manufactured to standard sizes, and they're designed to be user-friendly. Usually each company provides a few different sizes of abutments, a few different sizes of collars, and a few different diameters and a few different heights. They're typically used for cement retained restorations, and they could be used straight or angled. The limitations of the stuck abutments is usually that they have a uniform circular diameter. Well, as we know, teeth usually are not circular in diameter, which means that these are not the most anatomical abutments and they don't provide the greatest aesthetics. Also, that the margins can be minimally and only up to 1 millimeter, which sometimes lead to excess cement that is difficult to detect and remove in cases of subgingival margins. On the other hand, custom abutments, which are abutments that look like this, could be made for a particular implant. They can fix implant angulation issues and allow for flexibility in the margin position, unlike stuck abutments. They give more retention and they give a more anatomical emergence profile. They're usually used cement retained. Margins can be supergingival, as what we can see here, so we have less issues with cement. Could be casted or milled from titanium or zirconia using CAD/CAM machines. The only drawback that I see for custom abutments is the additional cost. I like this diagram. This is a diagram that I got from Atlantis, and the reason why I like this diagram is because it shows the difference between a stuck abutment and a custom abutment. So if you look at this bridge that we have here, if you look at the fitting surface, you would not really know if this was a fitting surface of a bridge that will be placed on top of an implant or on top of a tooth. On the other hand, if you look at the bridge on the right side, just by looking at the fitting surface of the bridge, you'll know that this bridge is made for an implant on a stuck abutment. Also, if you look on the bottom, you'll see the difference between the two. And now you'll see that on the right side, if we're using a stuck abutment, you'll find that the margin of the abutment is the way subgingival. Sometimes it might be very difficult to detect the extra cement that seeps around the implant, and sometimes that causes peri-implantitis and peri-implant disease. On the other hand, on the left side, you'll find that the margin on the left side here is at the level of the soft tissue, which means we'll definitely have a lot less issues with cement. Also in dimension number 4 is what we call AP spread. AP spread is the distance between the center of the two most anterior implants to the distal aspect of the two most distal implants. So this distance right here is what we call AP spread, or anterior-posterior spread. And it provides an indication of the amount of cantilever that can be planned reasonably. And this is what we mean by cantilever, which is the part of the prosthesis that is not supported by an implant. In Carl Mesch's book about implant biomechanics, he spoke about how much cantilever can be reasonably done, and according to him, the amount of cantilever should not exceed 2.5 times the AP spread with all stress factors low. So what does that mean? It means if the AP spread is about 10 millimeters, we can cantilever up to 25 millimeters. But again, I just need to focus on that little point right here that says with all stress factors low. What does if all stress factors low mean? So with all stress factors low means crown height is adequate, so we have enough height of prosthetic space, the masticatory dynamics and the presence or absence of parafunction, arch position, opposing arch and direction of force, bone density, implant number, width and design. So when all the factors up here are low and we have an adequate number of implants, an adequate width of implants, we have enough prosthetic space, we have low parafunction, we have high bone density, then and only then we can cantilever up to 2.5 millimeters of AP spread. But I think we could never get all these factors to be in one patient. So I think the word that says with all stress factors low almost never happens. So what we would say is a combination of all those factors give us an indication of how much cantilever we could do. I recommend going with a number that is more reasonable, whether 1-to-1 and sometimes less than 1-to-1. So how does that really affect us when we're doing the prosthesis? Well, if you think of the prosthesis as a four-legged table, as what we can see right here, in this particular case, we have legs at the front of the table and legs at the back of the table, and this will be a very stable table. On the other hand, in some cases, we have to move our implants a little bit to the front, and then we'll end up with a slightly less stable prosthesis. And in other cases, if we have a long cantilevered section, it's a lot less stable. This is pretty much how everything looks like in the oral cavity. So in some cases, ideally, I would love to have legs at the front, legs at the back, which means implants at the very front and implants at the very back. But in some cases, we can't really do that. So what we have to do is we have to go a little bit to the front. We have to cantilever one crown. And in other cases, we have to cantilever a little bit more, which pretty much decreases the stability of my prosthesis and might lead to a little bit more issues. So what are the AP spread limitations that we might face? Number one, in the maxilla, we have what we call the sinus pneumatization. So in a lot of cases, we have pretty big sinuses, and this is what's going to prevent us from placing implants nice and straight. On the other hand, in the mandible, in a lot of cases, we have severe vertical bone loss, which means that we'll be very close to where the inferior alveolar nerve is. So ideally, I would love to place the implants nice and parallel, as we showed in dimension number 4, but not in a lot of cases I can do that due to the limitations that we've just spoken about, like the maxillary sinus and the mandibular nerve. Okay, so how is it that I can get the same amount of AP spread? So I need to end up with the prosthesis with the most amount of spread possible, but in the meantime, how do I avoid going in the sinus or in the nerve? This is where we came up with the idea of canted implants or tilted implants, which is what we call the all-on-4 or all-on-X. So the all-on-4 technique was introduced by Dr. Paolo Malo and Nobel Biocare. This solution is applied in fully edentulous cases and severe bone loss cases. And what we do is we place 4 implants to restore a full arch of teeth with aesthetics and function. It reduces the need for bone grafting because we avoid going in the sinus and we avoid hitting the nerve. By tilting the 2 posterior implants at 17 or 30 degrees angle, ensures a secure and stable anchorage for the replaced arch, typically making bone grafting unnecessary. So you see here from the radiograph, we have as much AP spread as we would have with a straight implant. On the other hand, we're avoiding going in the sinus by tilting the implants. And what we do in these cases is we do full arch immediate loading. So let's go back to the 5 dimensions of treatment planning. We spoke about dimension number 1, which is Bucco-Lingual. We spoke about dimension number 2, Mesio-distal. We also spoke about dimension number 3, which is Apico-occlusal. And underneath Apico-occlusal, there's the relationship of important anatomical structures, bone level, running room, and native bone engagement. We talked about dimension number 4, which is relationship to adjacent teeth, implants, waxup, and AP spread, and how the relationship of the implants, if they're parallel or not, would make our procedure much easier, and restoring the implant will be a lot easier. And we talked about if we place the implant to be in a biological position, but where would the implants come out in relationship to the waxup? And if we need to correct that, we have to resort to using some sort of a custom abutment if necessary. We also talked about AP spread and how AP spread really affects our selection of the type of prosthesis that is going to be used. So in a lot of cases where we don't have a lot of AP spread, we have to resort to using a shorter arch. So we go with a premolar occlusion, and in some cases where we have a lot of AP spread, then in these cases we can give our patients a full arch of teeth. We could give them first molar occlusion, and sometimes we could give them second molar occlusion. Now let's speak about dimension number 5. Dimension number 5 is bone density and loading. And the question would be, why do we need to know the bone density? I think this is a very basic question, but sometimes the answer might skip our minds. So before I answer this question, let's lay out some facts. Fact number 1, we have higher failure rates for implants placed in the maxilla rather than the mandible. This is actually a fact, and the reason why is because bone density does play a role in implant's primary stability and subsequent osseointegration. If I place an implant with high primary stability from the beginning, the odds of this implant osseointegrating are definitely higher, and this is what we get in the mandible more than in the maxilla. Fact number 2, implant stability is not a one-sided coin, which means for me to get good primary stability, I have to look at 2 things and not only one thing. So the first side, it will be implant design. We usually try to use an implant with a good design, but as we said, implant design on its own is definitely not enough. So what good would the implant design do me if the osteotomy is a lot wider than the implant? Which means there are 2 things that go hand in hand. Number 1 is the implant design, and the second thing is instrumentation. How much drilling am I doing to place my implants? And am I using the proper amount of drills or not? Am I over drilling or am I under drilling? So the 2 factors of implant primary stability are implant design and instrumentation. And that leads me to the concept of customizing the drilling protocols. Drilling protocols could be customized after the assessment of the bone density in the future implant site, with the purpose of obtaining higher primary stability to avoid over-instrumentation and subsequent loss of implant primary stability. So that leads me to the question that I asked at the beginning. Why do we need to know the bone density? The reason why is because if we know the bone density before the surgery, I will know exactly how many drills I will be using so I can avoid over-instrumentation. And if I know exactly how many drills I'll be using, I'll also know how to place the implant with very high primary stability, and this is what we want. So how do I assess the bone density before the surgery? And this is a very important question. Hounsfield units. So Hounsfield units, what they do is they allow us to know the density of any object in the CT scan. So Hounsfield units is just a measurement scale to how dense an object in the CT is. So the least dense object is air, and these are the highest density objects above 1000, which is usually the density of the metal, and we have the midpoint is the density of water. So basically, just like we measure our weight with a kilogram, we measure the density of an object in a CT by using Hounsfield units. The more we go towards the right side, the more dense the objects are. The problem with Hounsfield units is that they use numbers, and we as clinicians are not really used to using numbers. So let's say, for instance, if I tell you that the bone density in this site is 850. What does that mean? In order for you to understand what the number means, you have to go to one of these classifications, whether Leco-Manzar classification or Misch's classification. The problem is, with Leco-Manzar classification, D1 is plus 850. On the other hand, D1 in Misch's classification is more than 1250, which means that there's a big discrepancy between the two. Also, D4 in Leco-Manzar classification is under 500. On the other hand, in Misch's classification, D4 is from 150 to 350. So see here that there's a big difference between the two. So that's number 1, and that's one of the main reasons why we're not using Hounsfield units to measure the density of bone in the CT. Also, we've had so many different studies that talk about the accuracy of measuring Hounsfield units in a CBCT. And what we found out that with most of these studies is that the multi-slice CT scan, which is the medical grade CT scan, is actually the golden standard, and this is what should be used for measuring Hounsfield units, not CBCT. And then there was a more specific study. This is a study that was done in Brazil. And what we have done here is we have got one patient, and what we did was we scanned the patient first with a multi-slice CT scan, which is a medical grade CT, and then we scanned the patient again with a CBCT scan. And then what we did was we compared the numbers. So what we found was the mean Hounsfield unit value obtained with a CBCT scan was higher than the one obtained with a multi-slice CT. How is that possible? And the difference is not actually a small difference, it was a statistically significant difference. And also Bland-Altman analysis showed that Hounsfield units were not equivalent. In conclusion, bone density in Hounsfield units with CBCT scan images obtained using the device studied proven unreliable. since it was higher than the ones that were obtained with a multi-slice CT scan, which is the golden standard. So, in essence, it's not very reliable to measure the bone density from a CBCT scan. It's a lot more reliable to do that with a multi-slice CT scan. The only problem we have is that we don't really have access to multi-slice CT scan machines in our offices. So what we need to do is we need to find an alternative method to assess the density of bone that does not use Hounsfield units. And this is where we came up with what we call the digital eye. So the digital eye is a new digital approach for us to be able to assess the density of any object in the CBCT scan based on their grayscale. So what we do with digital eye is what we transform the different grayscales of the image, which is 256. So what we do is we transform these colors through an algorithm from the gray image to a colored image. And this is how we end up with this range of different colors that we have here on the upper right side of the image. So let's look at the images that we have on the bottom here, and let's compare the two images. As we all know, the anterior maxilla and the anterior mandible are the most dense bone in the oral cavity. So if you look at the image on the right side, which is the image that was managed with digital eye, so what you'll see in the anterior maxilla right here is in yellow color. If we look at the top with the density scale, it shows that this type of bone is actually high density bone. The more we go towards the posterior, you'll find that the density of the bone decreases. So what we see here in this area, the predominant color is a blue color. If we translate what the blue color means in the digital eye scale, you'll find that this actually means medium density bone. The more you go towards the posterior, the density decreases. But before I show you the bone density in the posterior maxilla, I need to first lay out a couple of facts. In digital eye, we have certain parameters that never change. Number one, air is always black. So here in the maxillary sinus, you'll find that the air is black. The airway space is black. Also, soft tissue is always red. So here, these are the lips of the patient. And this is the soft palate of the patient. You'll find that it's actually in a red color. So if we go back to the posterior maxilla, can you imagine that the density of the bone at the posterior maxilla is similar to the density of the soft tissue? Is this something that you could have told by only looking at the image on the left side? So the idea here is we're trying to use this as a logical and a simple visual aid that will help us to distinguish the different densities of bone before the surgery without having to use Hounsfield units. So here, this is how D1 bone looks like. It will be mostly yellow and orange. And this is how D4 looks like. It will be mostly red. And this is how everything in between looks like. Please notice that this does not apply to grafted sites. The reason why is because it's not very accurate to assess the density of grafted sites by only using a radiograph. The reason why is because different types of bone has different radiographic appearances, and it does not reflect how dense this type of bone is. So what we recommend is to refer back to the manufacturer's instructions on what would be the optimal time to load each type of bone and how much time does it take for this graft material to mature. Now, based on the bone density analysis, we start to customize the drilling protocol. And this is what we do in the digital eye technology, is that after we know what the bone density is, we start to customize our drilling protocols. So in cases where we have D1 dense bone, this is a 4mm implant, and for my 4.0mm implant, my final drill will be 3.8 millimeters, since this is going to be D1 bone. On the other hand, if I place the same size implant in D4 bone, what we usually do is we skip a drill just to make sure that we'll get good primary stability, and this is what we call customizing the drilling protocol. Now, the great thing is with R2 gate system, every case that you do with R2 gate, you'll get an automated drilling protocol which will let you know how many drills you should be using to get the best primary stability in each site based on the bone density analysis that is done with the R2 gate digital eye. If we start to customize the drilling protocols, we'll get higher primary stability. Higher primary stability means new possibilities for immediate loading. And now the question would be, is immediate loading safe? Now this is a very important question, and a lot of people might say yes, a lot of people might say no. Let me tell you the answer. The answer is immediate loading is safe if done properly. So what does if done properly mean? And let's go ahead and talk about what does if done properly mean. For us to know if immediate loading is safe or not, we have to know how do we assess the implant's primary stability. So today I'm going to be speaking about three things. Number one will be peak insertion torque. Number two will be resonance frequency analysis, RFA. Number three would be implant stability quotient. And I have to tell you that number two and number three are pretty much the same thing, but I'll explain why later on I put both on this slide. So let me start with peak insertion torque. Peak insertion torque is the maximum value of insertion that we get during placing the implant. This right here that we see in front of us, this is what peak insertion torque is. So it's the highest value that we get during placing the implant. And now what I need you to remember is this, that it's a one-time measurement. How many times do you place your implant? Only once. So you can only measure insertion torque of the implant once, and that's the key point I really need you to remember. Please remember this part. Now we measured that with using a torque ratchet or with a torque measurement tool. The insertion torque value is a result of host jawbone texture, drilling protocol, and implant design. And again, this is more of a rotational type of force. Now, primary stability is not only insertion torque, and this is what Dr. Michael Norton says, who I'm borrowing a lot of his slides for you today. He said, we're not carpenters, we're clinicians, and primary stability is not only insertion torque. So, what else? There's also the concept of resonance frequency analysis. So what is resonance frequency analysis? If you remember back in the day in school, we used to learn what we call the tuning fork principle. So tuning fork principle, the idea behind it is, if I have a tuning fork and I hold this tuning fork in a metal stand, the fork will resonate with very high frequency. On the other hand, if I hold that same fork in my hands, it will resonate but with much less frequency. And the reason being that the principle behind RFA is the stiffer the interface that the fork is in, the higher the resonance frequency will be. So essentially, if we use the same concept with an implant, we use what we call the smart peg, which is basically a tuning fork. So the stiffer the interface between the bone and the implant, the higher the frequency, and the higher the frequency, the higher the ISQ. So we measure resonance frequency analysis with a measurement unit called ISQ. So resonance frequency analysis is the principle, but the measurement tool for resonance frequency analysis is ISQ, and ISQ means implant stability quotient. And you need to know that resonance frequency analysis is a more dynamic method to assess the changes in the implant stability over time and determine the loading protocol. So it's a dynamic method, unlike insertion torque. We said you only measure insertion torque once, but you measure ISQ over time, and it's a repeatable measurement. You also need to know that the difference between both insertion torque and ISQ is that ISQ really measures the implant's axial stiffness. It measures the resistance to lateral forces and not shear rotational forces. ISQ is measured from 1 to 100, and clinically what we get is about 50 to 85. This is usually what we get. And you should know that from 65 to 85 is considered high implant stability. And now I'd like to show you this video. I really like this video because it shows a very clear and nice representation of how an ISQ device works. So what we'll use now is we'll use some self-curing resin in a form of powder, and I'll mix that powder with the monomer. And while the material is still soft, I'll go ahead and I'll place an implant with a smart pig inside of the material. What I'll do right now is I'll measure ISQ, and I'll find right now that the ISQ is only 10. But if I wait for a few minutes until the material sets and I take another measurement, look how much the measurement is right now. Now this is the same implant, this is the same smart peg, but we get different numbers. And this is the idea behind ISQ. So what we can tell now is that the difference between both insertion torque and ISQ is that resonance frequency analysis, or ISQ, measures the resistance to lateral micro movements. On the other hand, resonance frequency analysis, on the other hand, peak insertion torque measures the resistance to shear rotational forces and is measured with Newton centimeter. And again, resonance frequency analysis is measured with ISQ. But what is the sole difference between peak insertion torque and resonance frequency analysis ISQ? Peak insertion torque is a one-time static measurement. Remember, we mentioned this before. You can only measure insertion torque once. On the other hand, resonance frequency analysis is a more dynamic method to assess changes in implant stability over time and determine the loading protocol. So, because we have access to such beautiful technology, we're really able to know the life cycle of a dental implant. When we place the implant, we place the implant with a certain amount of primary stability. Primary stability is a mechanical type of stability. It's mechanical in nature. But you'll find that after a few weeks, we get a drop in the implant primary stability. And the reason why is because we start to lose that mechanical stability at the beginning, and now this is the peak of transformation from mechanical stability to what we call biological stability. So secondary stability of the implants is not mechanical, it's more biological in nature. And this is one of the things that using ISQ actually enabled us to know. So in the literature, we're really trying to find, is there any relationship between insertion torque and ISQ? If I place the implant with high insertion torque, does that necessarily mean that I'll get high ISQ? Well, let's see. So we've seen a lot of studies that have been on the topic of trying to find the relationship between insertion torque and ISQ, and actually there is no correlation between RFA and insertion torque. So sometimes you might place the implant with 31 Newton centimeter and you'll get an ISQ of 82. In other cases, you might place an implant with 102 insertion torque, but you only get 81 ISQ. So basically, getting a high insertion torque does not necessarily mean that you'll get a high ISQ. So these are the two most cited, and these are the two most documented and talking about methods to assess implant stability in the literature. Would you use insertion torque, or would you use ISQ, or will you use both? And the answer is actually both. So if we have to talk about the criteria for immediate loading, what would be the safest criteria for immediate loading? Well, what we did was we divided this into three different groups based on three different clinical scenarios that you might face. Number one, a single restoration. Number two, multiple restorations in the form of a bridge on one side, for instance, and a full arch restoration with what we call the cross arch splinting. If I place a single implant with 45 Newton centimeter and 75 ISQ, it is actually considered safe to load this implant. If I place the implant with 40 Newton centimeter with 70 ISQ and I have multiple implants in a bridge, I can actually load these implants immediately. And lastly, if I place multiple implants with 30 Newton centimeter and 65 ISQ, I can actually load these implants if they are splinted in a full arch type of prosthesis. Which means the more implants I have and the more implants that are splinted, the less the readings have to be. So now you see that we have mentioned both insertion torque and ISQ as fundamental methods to determine if it's actually safe to load these implants or not. But have you really noticed this? Is that on a scale that goes from 1 to 100 ISQ, most of the readings that would allow us to do immediate loading were actually between 65 and 75. And why is that? The reason being is that ISQ and micromobility have what we call a nonlinear relationship. So micromobility decreases approximately 50% between 60 and 70 ISQ. This is how much decrease we get in micromobility only from 60 to 70. So this is very important for us to know that we have what we call a nonlinear relationship between ISQ and micromobility. Now that we mentioned that, let me start by showing you the first clinical case of a patient that wanted to restore both those crowns on the right side and on the left side of the first molars. So we started out by taking a CBCT for the patient. I always scan them with the lip or cheek cleft technique. This is a technique that was introduced by Dr. Scott Gans in the literature. And as you can see here, this gap that we have right here was actually formed by adding some cotton rolls between the patient's lips and the patient's mucosa. So the lip cleft technique really allows us to get a lot of information from our CBCT, and it lets us know a lot of information about the type of tissue that we have. How thick is the tissue, and what is the biotype that we have for this patient? You see here, only by adding these cotton rolls, you see this big pocket of air, and this is what allows us to see the soft tissue really well. For that, you could use either cotton rolls or you could use the Optra Gate, which is a retractor. I personally use cotton rolls. I find that this is the cheapest and the most convenient method to do the lip or cheek cleft technique. And I always plan based on the 5 dimensions of treatment planning. So this case was planned based on the 5 dimensions. And because I scanned my patient using the cheek cleft technique, I was actually able to push that tissue away. And because I pushed the buccal tissue away, I was able to measure exactly how thick the soft tissue was. In this case, the thickness of the soft tissue was only 1.5 millimeters, which means that it was pretty thin. Even though this type of tissue was actually keratinized tissue, the decision to punch or flap the tissue is really based on the quality and the quantity of the tissue together. By quality, we mean is the tissue keratinized or not, and by quantity, we mean how thick is the soft tissue. If the soft tissue is thin to begin with, do not punch the tissue. We would recommend that you do a flap in this case. So in this case, I decided to do a flap. And now, based on the bone density analysis in digital eye, I knew that this type of bone that I have here is very dense bone. As you can see here, it's mostly yellow, which means that this is D1 type of bone. My final drill is going to be 4.3 millimeter drill. In this case, I prepared the restoration before the surgery to do immediate loading. And this is everything I have done before the surgery. And now in the surgery, the first thing to do would be to raise a flap based on the information that we got from the lip or cheek cleft technique. And then we started to do the drilling through our surgical guide based on the drilling protocol on the bottom. We used cortical bone drills also in this case. And then the implant placement was also done fully guided. In this case, we actually ended up with more than 45 Newton centimeter insertion torque for both the implants. So we measured ISQ for both implants. For implants number 36, I got 79 ISQ. For implant number 46, I got 75 ISQ. So what does that mean? It means that based on the safe immediate loading criteria, for a single restoration, it is actually considered safe to load this implant with 45 Newton centimeter and 75 out of occlusion. So here, this is immediately after placing the implant and the temporary restoration as well. And this is how the patient looks like with both restorations in the mouth. But do we always get these numbers in every case? Do I always get 45 Newton centimeter and 75 ISQ? Actually, no. So let me show you this case that we have right here. So in this case, the patient was actually missing 2 lateral incisors. These were congenitally missing incisors. And the treatment plan here was to place 2 implants in these sites, 2 mini implants. So what we started out with is doing a digital oral design. A digital oral design is the concept where we merge all the data of the patient together. We merge the CBCT with the model, with the photograph of the picture, or the picture of the patient. And this was actually before we started out to integrate facial scans as well. So this is what we have here. This is a combination of all the patient's data. And the reason why we do that is because when we do a smile design that will eventually allow us to design the prosthesis, we would like the prosthesis to look good on the patient's face. So we started out with the oval design, and then we started out with a rectangular design. And what we found was maybe the triangular design would be the best looking design on the patient. So based on this information, we're able to actually extract this information, and we're able to design the temporary restoration to look exactly like what we have in the smile design. So this is the planning and the R2Gate software, and as you can see here, we use 2 implants. These are mini implants from Megagen, 3.0 millimeter by 13. This is the temporary restoration that was done prefabricated. This was done before the surgery. So this is how everything looks like intraorally. So we started out with laying a small flap, and then we started out to use our guided drills. And after that, we've used the osseodensification burst to increase the quality of bone in these sites. And then we placed our implants nice and guided. So we placed the implants with only 25 Newton centimeter in this case. In this case, I was really excited to know how the restoration would look like on the patient's face. So we tried it, and obviously everything looked pretty good. But then I remembered that we also need to measure ISQ. And when we measured ISQ, I found that I got only 68 ISQ in this case. So now, if I got only 25 Newton centimeter and 68 ISQ, would that be enough for me to actually load the implants immediately? So when I went back to my loading criteria, I found that what I need for me to actually load the implants immediately, I need 45 Newton centimeter, which I only got 25, and I need 75 ISQ, and I only got 68 in this case, which means that in this case, it is not actually ideal to load the implants in the same day. And what I did in this case was I actually sutured the patient up, and I let the patient go without loading the restorations. But actually, I knew that this would be the right clinical decision because the implants were not ready to be loaded yet. So why ISQ? Why would I need to use ISQ? The ISQ is actually an objective measurement of implant stability, and it also supports making the right decisions about loading or delaying, as you just saw in the previous cases. It gives an indication on what type of loading protocol will be followed, whether to do 1 stage or 2 stage, and how long do we wait until the implant is actually ready to be loaded. So let's talk about this part for a little bit. In the cases where I can't do immediate loading, how long should I wait before I bring the patient back to do the loading? And this is the question that needs to be answered. For us to actually answer this question, let's go ahead and look at this diagram that we have in front of us. So as we said previously, if we get more than 70 ISQ, we could actually do immediate loading, or we could do just a 1 stage. In cases you would like to delay the immediate loading, let's say it's a posterior case and the aesthetics are not really of a big concern, you could just place the implant, place the healing abutment, and do early loading. If you get 65 to 70 ISQ, in a partial case, you could do 1 or you could do 2 stage, but you could actually do early loading. So you could come back after 6 weeks and load the implants. If you get 60 to 65 ISQ, if you have a full arch case, you could actually immediate load the full arch case, as long as we have what we call full splinting or cross arch stabilization. Or if you have a single restoration or a partial, do a 2 stage and do traditional loading, which means that we should wait a little bit longer. We should wait about 3 months. If you get less than 60 ISQ, it means that this implant has a very low primary stability, and ideally you should monitor the ISQ of this implant over time. Now, let's say you waited for 6 weeks. Now the patients come back. If you measure ISQ again, and the readings are either equivalent or higher than the initial readings, it means that this implant is actually ready to be loaded, since it's already past the dangerous stage or the dip in the primary stability that we talk about. And this is how you minimize the waiting time, and this is how you become more efficient by using such technology to give our patients the crowns faster, and I guess this is what they will really appreciate. Today in my presentation we talked about the 5 dimensions. I hope that the 5 dimensions of treatment planning were quite clear to you and will actually help you in whether in your clinical practice or when you're planning an implant with your implant planning software. My take-home message for the 5 dimensions of treatment planning is implant planning should be done with a great deal of accuracy, and that's why we came up with the 5 dimensions of treatment planning. Those 5 dimensions of treatment planning are the blueprint that will be followed during the process of implant planning, and this will allow us to plan in consideration to a restorative position availability of bone and soft tissues, and will help us make good clinical decisions on when to load our implants. Thank you so much for listening to my lecture about the 5 dimensions of successful treatment planning. My name is Dr. Sam Omar. This is my email. In case you have any questions you'd like to ask me about the 5 dimensions or any other topic, please feel free to send me an email at dr.samomar@gmail.com. Thank you so much for listening, and we'll see you on the next one.